seminar is on danger sign of pregnancy, which is being hosted by Blue Ethiopia in partnership with Ankara Technologies, their Learnat project. So by the end of this session, so this session will last for about 1 hour. So we appreciate Learnat for sponsoring this seminar. So I think Dr. Dawit, you can start the session now. So thank you.
Okay, Doc. Thank you. So my name is Dr. Dawit. I'm obstetrician and gynecologist and the department head of obstetrics and gynecology ward at Saudi Memorial Hospital. And I'm so glad to have this session, to give this session for the practitioners. And this session is going to last around 40-50 minutes. And it's going to be a very crucial topic for healthcare professionals, specifically frontline healthcare professionals who is going to have contact with pregnant mothers. So the topic is going to be danger signs of pregnancy. So as the name implies, there are danger signs that we need to focus on. So danger signs or warning signs of pregnancy are signs and symptoms that a pregnant woman is going to experience, and that could mean that she is sick or there is some problem that's going to happen, so that these signs and warning signs are going to be an alarming sign and symptoms that the pregnant woman need to seek treatment, seek healthcare professional advice. So basically, there are places where these women could have contact with. For example, these women will have visits, which we call it antenatal care follow-up. And this antenatal care follow-up is a well-organized care follow-up, which is going to be given by healthcare providers. And the main aim of this this antenatal follow-up is going to be giving advice on different aspects of the pregnancy, and this could be nutritional advices, medication supplements, and one of the major issues that we are going to discuss today is going to be on danger signs of pregnancy. So these danger signs of pregnancies are going to be introduced, are going to be told to these pregnant moms during the start of the first ANC contact. Okay, so one thing that we need to understand is knowing or understanding the signs of pregnancy is not going to be given for only high-risk pregnant mothers. Of course, we classify pregnant women as basic ANC follow-up and high-risk ANC follow-ups. But the advice that we are going to give is not only for high-risk pregnant women, but also we need to give this information as well for basic ANC follow-ups. We say high-risk pregnant women, those who have a previous history of danger signs. For example, those women who have previous scars, those women who have previous pregnancy complicated with bleeding, hypertension, and so on, we consider them to be high-risk pregnant moms. But those women with no complications, we classify them under basic follow-up. But still, even if they are under the basic follow-up list, it doesn't mean that they are not at high risk. Okay, every pregnant woman is at high risk. Okay, so we need to give them this advice, this danger signs, so these advices for all of them. So what is the need of giving them these advices? What's the need of giving them insight about danger signs of pregnancy? The reason is just so that they are going to think about it, they are going to decide where they will go if they have experienced one of the signs and symptoms. So we need to give them proper advices. So at the end of this session, we all will have we all provide or information about the danger signs and complications during pregnancy and childbirth, and we'll be able to support women while planning where to go and how to get there quickly if any emergency arises. And also, we'll develop effective communication on how to access emergency care and when a danger sign is going to be recognized. And the other most important thing is also addressing. We'll be able to understand how to address these danger signs to the family, to the client, and to the general to the community as well. Okay, so what are the most important danger signs of pregnancy? So basically, we can classify there are some signs and symptoms which need an immediate action. Okay, so that the patient has to go immediately to the healthcare center to seek healthcare setup. Okay, so these are the vaginal bleeding, convulsions, severe headache with blurring of vision, fever, and too weak to get out of bed, severe abdominal pain, fast or difficulty of breathing. This we consider them to be immediate that need immediate action. Okay, immediate action. And there are some symptoms that we consider them to be not as such a very immediate, but also they may give us some time, but still they need evaluation as soon as possible. Okay, so this could be fever, low grade fever, some kind of crampy abdominal pain or abdominal pain of any kind, a feeling of illness, any swelling in the fingers, face, legs. Okay, these also are danger signs, but then we may not as such consider them to be an immediate, but still the patients need to visit the healthcare setup as soon as possible. Okay. So the other thing that we need to raise is about communication. Communication, okay? So communication is very important whenever we are dealing with danger signs of pregnancy, because as we know, most women have uneventful pregnancy in childbirth, but sudden and unpredictable complications may happen at any time T for a woman who is on the follow-up or at the ANC clinic, okay? So whenever these complications happen, or whenever the patients start to have these danger signs and symptoms, okay, we need to have a way to address these things to the patient, okay, so that the patient, the family could possibly understand. So what are the ways in which we can be able to address this sign and symptom to the patient? So basically, it has to be familiar terms and with the local words so that the patient can be able to understand. And it has to be in a very clear way that the patient could be, it means like we don't need to use some kind of medical terms in this way so that the patient could be understand. And we have to be able to, whenever we do these things, we have to be we need to be leaders on how to intervene as well, because the patients are illiterate, they don't know anything, they don't know how to manage it, and so on and so on things. So we have to, as a healthcare professional, not only exposing these danger signs, but also we need to be able to know, we need to be able to lead them on how to treat the complications as well, okay, so that the patient will be in a relief way. So whenever we do that, we have to try to discuss emergency plans as well, okay, in case of transportation to where to go and the nearest health center, and also some logistic details. Everything has to be discussed with the patient as well. So if the patient is literate, we can give them some kind of leaflets, fact sheets, some other methods of understanding the danger signs has to be given. And for illiterate patients, usually we have to be verbal communication, pictorial methods of understanding the complication has to be properly given. Okay, and the other most important thing is wherever we explain these danger signs, we have to be a little bit realistic on description. So that would be helpful to identify the signs of emergency. It doesn't mean that we shouldn't hide anything. We shouldn't, it's just like we don't need to make them frightened, okay? We have to tell them the proper thing in a truthful manner, but it shouldn't be in the worst case scenario, okay, so that the patient is going to be frightened, and at least we have to avoid those frightening things. The focus should be basically on recognition of the sign and awareness of what to do if things are going wrong. Okay. The other most important thing is we have to reassure them as well. The patients usually, as I try to explain, they don't know as we know. So basically, whenever we tell them, they may be a little bit panic and so on. So we have to be reassure them that we are going to do everything that we can, and at least we have to try to alleviate their fears and support them. But one thing that we need to know is we have to be able to answer every question that they are going to ask. But our answer has to be it has to be a little bit truthful. Uh, we shouldn't give them a false promises or reassurance about the pregnancy outcomes. For example, a patient with hypertensive disease of pregnancy preeclampsia at 26 weeks of gestation. If she came with severe hypertension, usually the management we know is it's going to be termination because it is remote from term. But if it is the pregnancy is very desperate, if she wants to continue everything, we need to be frankly able to tell her the complications that could possibly occur in the side of the mother as well as in the side of the neonates, the fetus. So frankly, we have to be able to tell her the complications that could happen, so that we have to be a leader on the management process. But finally, the decision is going to be theirs. Okay, so and now we're going to see the most important danger signs and warning signs. So the first warning sign that we are going to see is signs and complex of hypertension or preeclampsia. So basically, patients with signs and symptoms of preeclampsia usually present with headache. The first and the most important sign is severe headache. Usually, in pregnancy, there are different things that could cause headache. There are minor headaches. So basically, this could be some kind of dehydration, due to dehydration, lack of sleep due to the pregnancy discomfort, noises, and other things could be cause for minor headaches. But severe headache, always, it has to be a very suspicious concern, because severe headaches, the worst headaches that could be experienced during pregnancy, is one of the major signs of preeclampsia or hypertensive disease of pregnancy, and it's also a major sign of impending eclampsia. So always when a patient describes a feeling of the worst headache, that is not going to be treated by possible analgesics, medications, and potentially if it is associated with visual disturbance like blurring of vision, dizziness, we should be suspicious enough to diagnose preeclampsia or hypertensive disease of pregnancy. So in these cases, it's an immediate danger sign that the patient needs to seek medical attention. And the other thing is visual disturbance, specifically if it is associated with headache, we should consider preeclampsia and hypertensive disease. But there are also other possible differential diagnoses that we could anticipate, whenever a patient with pregnant patient with visual disturbance. One of them is hormonal changes, some dry eye, and gestational diabetic mellitus. This also could be a cause for visual disturbance. And the other most important thing that patient with hypertensive disease of pregnancy could be presented with is unconsciousness or seizure. So basically, this is one of the major complications of uncontrolled hypertension during pregnancy or preeclampsia. We call it eclampsia. So basically, it means coma or abnormal body movements, that occurs in the setup of preeclampsia. We consider it to be eclampsia. But one thing that we have to know in pregnancy, there are different differentials that we could also consider that could also cause unconsciousness or seizure. So at least we have to be able to rule out the major ones like cerebral malaria, okay, and hypoglycemia and cerebral infections. At least we have to be able to rule out and rule in these major causes before we entertain eclampsia, because as the definition implies, eclampsia is somehow it's a diagnosis of exclusion. So at least we have to be able to rule out and rule in other causes of eclampsia, abnormal body movement before we entertain eclampsia. Okay, so another and most important sign that we need to know for hypertension is extreme swelling of the face, arm, and legs. Basically, swelling of the leg is not as such a big thing or a danger sign that a pregnant woman could have. Okay, basically, every pregnant woman could have at least grade 1 or grade 2 edemas. Okay, but this sign is just due to compression of the inferior vena cava by the gravid uterus. Okay, so that there will be sluggish return of venous return from the lower extremity, so that there is some kind of extravasation of fluid from the intravascular to extravascular space, so that the legs could be swollen up. Okay, so this is a transient whenever the patient has long hour of standing work, long hour of sitting, okay, long travel and so on. Usually this pregnant mother could have these symptoms, and this is not as such a danger sign. But whenever the woman has non-dependent side edemas, like for example facial edema, periorbital edema, okay, and if she has some kind of ascites, if she develop abdominal wall edema in a grave consequences, if the patient develop collection of fluid in the lungs, which we call it pulmonary edema, vulvar edema, and so on, that is a sign of complication of hypertension. So the swelling that worries us has to be those swellings that are on the non-dependent areas or gravity non-associated areas. For example, in the periorbital area, in the facial area, and so on. Okay, basically, when we see the pathogenesis of preeclampsia, usually they cause capillary leak syndrome, which means the capillary is leaky and there will be fluid in the collection in the extravascular spaces. So non-dependent area is the commonest manifestation of preeclampsia or hypertensive disease of pregnancies, basically. Okay, so the other one is dizziness, fainting, and unconsciousness. Okay, so basically one of the major danger signs that we should always assess is the signs and symptoms of anemia. Okay, so patients with anemia usually will present with sign and symptom like dizziness, fainting, lightheadedness, easy fatigability, palpitation, okay, easily tired, more anything could happen whenever a patient has anemia. In fact, anemia is one of the major complications of pregnancy, but it is physiologic change. Physiologic anemia is the commonest, but some women may develop pathologic type of anemia. So usually we have to be able to address these signs and symptoms whenever we have a contact with a pregnant mother each time on her visit. Okay, but the other thing is still, even if our top differential diagnosis for dizziness, fainting, and sometimes unconsciousness is anemia, but we could also have to be able to know the sugar level of the patient, because hypoglycemia is also one sign of dizziness and fainting, and also hormonal changes. Okay, those pregnant women who work like standing for a long period of time, and this all could experience this kind of symptoms. Okay, so one thing that we should always be able to understand is our top differential has to be anemia, but at least we should be able to address the other differential diagnosis as well. Okay, so the other and most important danger sign that we should be able to address in each contact is high grade fever and high temperature. Okay, pregnant women could have these signs and symptoms at different times of her pregnancy, but it is always pathological. Okay, Usually, pregnant women are at the immunocompromised states. They could be prone for different types of infections. Okay, like for example, UTI, kidney infections like pyelonephritis, common cold, flu, food poisonings, and so on. Things could rise their temperature. Okay, high grade fever. So always, whenever the woman has this high grade fever, okay, it is a danger sign for pregnancy. Okay, and sometimes during third trimester and second trimester, due to rupture of the membrane, okay, the woman may develop high-grade fever and temperature, okay. This we call it chorioamnionitis. So basically, infection of the chorion in the amnion could also be a sign of infection, okay. So in this time, we need to tell her to go to the hospital as soon as possible, okay, because infections of the chorion and the amnion will affect not only the mother, also the baby. Okay, the mother will develop endometritis or postpartum uh, purpular sepsis. Okay, and the baby will have a tendency to be admitted to the neonatal ICU with early neonatal sepsis. Okay, so basically, if the woman has this kind of complications, we should be able to address her properly, how to do and where to go at the time. Okay, and also not only during the for the mother and for the neonate during the process of delivery, but also in the postpartum. Okay, risk of endometritis, risk of surgical site infections, and so on. So on things will appear to the mother. So always we have to be vigilant enough to tell these signs and symptoms as soon as possible. Okay. And the other thing is difficulty of breathing and chest pain. The pregnant mother could also have this kind of, usually physiologically, the pregnant woman will have increment in the respiratory rate and pulse rate somehow. But we should always we should always think that this rise in the pulse rate and respiratory rate is always in the normal range. Okay, this is physiologic change. But if the patient has difficulty of breathing, and if she has if she has some kind of chest pain, okay, it is pathologic for the mother. Okay, always we should think of some differential diagnosis like cardiac problems during pregnancy, peripartum cardiomyopathy, which is the commonest cardiac disease which occurs during the third trimester, intrapartum, and in the postpartum period. Usually, the patients present with some kind of ankle swelling, low blood pressure, and fatigue. And also, we have to be able to dig history of asthma, and also one of the complication of preeclampsia and so on, pulmonary edema and pulmonary embolism. Okay, usually pulmonary embolism patients will the presentation will be cough with frozen sputum and so on. Okay, so there will be blood clot gets stuck in the arteries in the lung, so that the patient will have this cough, chest pain, shortness of breath, and so on. Okay, and the other danger sign always we have to tell the woman is about decreased fetal movement. Okay, always, as we all know, the fetal kick will start to appear during starting from the 16 weeks to 18 weeks for multigravids, and starting from 18 weeks to 20 weeks for primigravids. So basically, there are some situations that actually could decrease the fetal kick, like for example, the location of the placenta, especially if it is in the anterior side. Okay, anterior side. Usually, the fetal kick might be a little bit decreased. The condition of the patient, if the patient is obese, she might not feel as it is needed, or if there is some complications like polyhydramnios, sometimes the patient might not even feel it. Okay, physiologically, the fetus, if it is in a sleep state, also the pregnant mother might not even hear it. Okay, so these are the non-normal situations, but sometimes, okay, we have to be able to address to the woman how is the progress of the kick. Okay, usually the progress of the kick will be increased up until the third trimester. Okay, but after the third trimester, when the fetal weight started to increase and occupy more space in the uterine cavity, and there will be decrement in the amniotic fluid somehow. Okay, so the baby might not move as it is expected, and there may be a little bit of decrement in the fetal movement. Okay, but always, whenever we tell the patients, they shouldn't come whenever they don't feel the fetal movement. Okay, always we should address to them when the fetal kick decreased from the usual time. They should see or visit the health center. That's how we should advise them. Usually, we just tell them just come when there is decrement in the fetal movement. That's what we should do, not when the fetal movement is absent. Okay, so there are other most important things that are associated with decrement in fetal movement, which are related to placental insufficiency. Basically, oligohydramnios secondary to preeclampsia and so on are also associated with fetal movement decrement. Basically, the fetus doesn't move due to lack of nutrients, due to insufficiency of the space, and so on. So always when the mother complains these things, we need to do ultrasound. She should have ultrasound evaluations and so on properly. Okay. And other most important danger signs that we need to discuss is about bleeding from the vagina during pregnancy and also abdominal pain. Okay, so here bleeding from the vagina during pregnancy could occur at different trimesters. Okay, and the causes are also different during different trimesters. So basically, the first trimester we consider it to be up to 12 to 13 weeks. Okay, so if there is bleeding, at least from the first trimester and the second trimester, there are top differentials that should come to our mind. Okay, specifically abortion or miscarriage, ectopic pregnancy, and molar pregnancy has to be in our mind. Top differential diagnosis. So every pregnant woman who came with vaginal bleeding during the first trimester, okay, at least we should be able to at least address the amount, the severity of bleeding. We need to test for pregnancy. We need to test for ultrasound, okay, so that we should act upon properly and in a proper manner. Okay, so always there are pre-signs before the bleeding appears. Okay, like crampy abdominal pain. Okay, any danger signs. Okay, like for example, if she was moving a long distance by foot, any other things. Okay, we have to be able to dig some kind of history as well. And also, we have to be able, most of the differentials, specifically the top differentials, like ectopic pregnancy, molar pregnancy, and abortion, usually they present with bleeding and also abdominal pain. And also, all the pregnant women will be that we consider them will be amenorrheic. Okay, so at least clinically, we have to be able to differentiate how abortion is different from the molar pregnancy based on the pattern of bleeding. Usually the bleeding will be darker in case of abortion with conceptus tissue, whitish tissues. In case of molar pregnancy, the bleeding will be accompanied by vesicles, okay, vesicular tissues. Okay. In case of ectopic pregnancy, usually the bleeding will occur, but it's more of spotty type of bleeding. Okay, spotty type of bleeding. So at least this is historically, and we have to confirm it by sending for proper investigation modalities. Okay, so the other and the most important complication or danger sign that we should be able to that we should be able to address is bleeding in the third trimester, which is after 28 weeks of gestation. Normally we consider it to be FH or antepartum hemorrhage. So basically the definition starts in our setup starts from 28 weeks up until delivery of the last fetus. Okay, so there are different differential diagnoses that we could entertain whenever we see bleeding in the third trimester. And most of the commonest differential diagnoses are placental abruption and placenta previa and vasa previa. Okay, these are placental causes of bleeding in the third trimester, but also we have to be able to entertain other non-placental causes of bleeding like coagulopathy, local causes like cervicitis, polyp, leech infestation, and cervical C, and so on and so on. Things has to be also entertained in the third trimester. Okay, so when a woman presented with bleeding at any trimester, okay, at least we have to be able to lead her properly, and ABC of life has to be our first and top priority. Okay, so the next danger signs that we are going to discuss is about leaking from the vagina, leakage of liquor from the vagina. Okay, one thing that we should always be able to understand is we have to be able to characterize the leakage of liquor. Okay, so history is very important. History is very important. Okay, so our top differential here is rupture of membrane. Rupture of membrane, which occurs in the second trimester, we call it to be inevitable abortion. Okay, and after 28 weeks, we consider it to be rupture of membrane, PROM. Okay, premature rupture of membrane. So the complications that has to be anticipated when a woman has a leakage of liquor at preterm time or during term times are usually there will be signs and symptoms of infection. Okay, whenever a woman has this leakage of liquor, the internal environment, intrauterine environment, will be exposed to the external environment. So bacteria will have easily access to enter into the amniotic cavity, and complications that we call it chorioamnionitis will be our major concern. Okay, so the patients will present with lower abdominal pain, okay, fever, okay, and foul smelling vaginal discharge. Okay, so this is a life-threatening condition. If we are not able to properly start them on antibiotics, if we are not able to address and start them on termination process, usually the uterus will be infected, okay, and the baby might even expire inside the uterus, and even after delivery, the chance of admitting to the neonatal ICU will be very high. Okay, so it's a life-threatening condition if we are not intervening properly. Not only infection in the uterine area, but also uh, systemic infection will be another disaster. Okay, so sepsis, septic shock, ICU admission, everything will possible complications that could appear if we are not properly address these complaints. Okay, okay. The other and the main danger sign that we should also address is limb pain and swelling. Usually, this limb pain and swelling they are one of the signs specific, especially if the pregnant woman present with asymmetric type of lower extremity swelling. Okay, our top differential that has to come to our mind is about deep vein thrombosis. Okay, usually they will have swelling, pain, tenderness. Okay, usually at the calf and in one leg area. Okay, it's a little bit painful. Okay, so always in this type of setup, okay, it's an emergency situation. Okay, unless otherwise anticoagulates. If the patient is not anticoagulated, usually the risk of pulmonary embolism and other complications will issue. Okay, so always limb pain and swelling, specifically asymmetric type of pain, okay, asymmetric type of swelling of the lower extremity should alert us. Okay, and the other and final danger sign that I want to discuss is about persistent nausea and vomiting. Okay, this is one of the major complications, the major danger sign that appears during the first trimester of pregnancy. Okay, specifically pre-gravid mothers or mothers who are first pregnancy are tend to have this complication most of the time. So we call it hyperemesis gravidarum. Normally, morning sickness, the so-called morning sickness in the layman term, morning sickness is a common complaint that could appear for every pregnant woman. Okay, so basically, starting from the 5 to 6 weeks of gestational age, every woman might have this nausea and vomiting, especially in the morning time. Okay, and in some of them, it might increase and reaching peak situation at around 9 weeks of gestation, and eventually it's going to go down and decrease and disappear at around end of third to fourth months of pregnancy. Usually, it is associated with the hormone human chorionic gonadotropin, okay, which is HCG. Usually, the level of HCG is going to rise up and peak at 9 weeks of gestation. That's why these symptoms are more related to this hormone. Okay, so usually, if the nausea and vomiting is persistent and protracted, and if the woman starts to lose weight, which is around 5% of her pre-pregnancy weight, and on the investigations, if the pregnant woman has ketonuria, okay, these are the diagnostic criteria to say hypermesis gravidae. Okay, so usually these pregnant women need to have hospital admission. They have to be replaced with fluid. Their electrolyte has to be checked, and antiemetics has to be provided, and energy requirements has to be made properly with glucose. Okay, and also we have to be able to tell them specifically for those women who have this non-persistent or just basically nausea and vomiting during pregnancy, we have to be able to tell them the proper advices, okay, during the NC follow-up. Usually, we have to tell the woman that we have to reassure her that this is a temporary situation that is related to hormonal consequences, okay, and possibly sooner or later that when the hormone level decreases, that's going to disappear, okay, so that they will be cognizant and get relief somehow, okay, and we have to be able to tell them to modify some of the situations at their home as well, okay. They have to decrease perfume, they have to refrain from areas where their food is produced, food is cooked, okay, and we have to be able to tell them proper way of taking meals, specifically small meals, frequent meals, okay, cold meals, non-spicy meals, as well as non-sweet types of meals are more encouraged for pregnant women with nausea and vomiting, okay. So basically, if they are above this situation and if they are unable to perform their day-to-day activity due to this nausea and vomiting, protracted nausea and vomiting, it's an alarming sign, it's a warning sign to seek medical advice. Okay, if we are not able to properly replace the fluid, replace their energy, usually the complications are grave. Okay. I think I have finished the major type of danger signs. If you have any questions, you can ask me. Thank you.
Okay, thank you very much, Dr. Dawit, and for the very informative and clear presentation. So participants, if you have any question regarding the topic, you can write it in the chat box so doctor can address.
Okay, I think one of the questions that was raised was what home remedies can a doctor recommend for swelling of legs, and when should be the cautious for swelling of leg and face? Okay, so basically, as I've tried to explain earlier, swelling of the legs is somehow not a danger sign because usually it's related to long hour working, standing position or sitting position, okay, long hour of walking and so on, okay. Usually this is a transient, as I have tried to say, So whenever the pregnant woman came with this kind of things, she has to elevate her legs with a pillow or something, okay, whenever she sits and whenever she sleeps, okay. But if something that should be cautious enough for us is if the pregnant woman has non-dependent types of swellings, which means against gravity, which is in the face areas, periorbital areas. Usually these are sudden types of swellings, okay, not progressive. And especially if they are accompanied by some kind of blurring of vision, headache, and so on, we have to be vigilant enough to send the patient to the hospital for better investigations.
There's also another question. So, is it normal to have how to respond when such things happen as a first aid giver? Robson, so could you clear that question?
Okay, up until it is going to be cleared, what
And
is it normal to have vaginal spotting or blood without any abdominal pain during any trimester or pregnancy? Usually, our top differential on the first pregnancy is these three complications that I have tried to say previously: ectopic pregnancy, molar pregnancy, and abortion. But implantation site bleedings are also another common things that every pregnant woman could have a complaint. Sometimes they do have some kind of spotting without any abdominal pain or back pain. That's a normal thing, but still, always these things has to be investigated, even if they have no any kind of pain. She should see her obstetrician for any ultrasound investigations. The other is what kind of diets should we advise for pregnant women experiencing excess nausea. So basically, as I've tried to explain, okay, the meal is going to be patient preference, because the first 3 months of pregnancy, pregnant women are more of selective. They may not be interested for any kind of food, okay? So always they should be focusing on the diets, the meals that they want, okay? But always whenever they take their meal, it has to be very small, like 2 to 3 bites, and it has to be frequent, like 2 to 3 hours, okay? And it shouldn't be taken like in a normal person, like in the morning, like a breakfast, lunch, and dinner, okay? This thing will create some kind of congestion in the stomach that will trigger the nausea and vomiting. And the same thing in the contrary, they shouldn't be starved. Empty stomach is also another sign for the triggering of this nausea and vomiting. So the meal has to be small and frequent. It has to be non-spicy foods. It has to be cold foods and non-sweet type of food. And also ginger is also is advised for ginger mint, and tea is also advised. Okay. The other is, can a pregnant woman take any kind of anti-pain like diclofenac or ibuprofen for minor headache with no other complication? No. Usually, the preferred type of anti-pain that a pregnant woman should take is paracetamol or acetaminophen. Okay, we don't recommend a diclofenac because it has some congenital malformation effect, and also ibuprofen as well. Okay, so the preferred one is paracetamol. Okay, if it is more than paracetamol, preferably tramadol and others IV and IM injections are preferable. Is depression and anxiety during pregnancy a danger sign, especially women having previous obstetric history? Very good. This is very important. Yeah, we have, by the way, the signs and symptoms, danger signs that I have listed on the presentation. They are at least the most of the danger signs. But still, depression and anxiety and threatening conditions for the pregnancy as also considered to be danger signs. Okay, but always the pregnant woman will have this kind of danger sign if she has some bad obstetric history in the previous time, or if if the pregnancy is unwanted, unplanned, or if it is some kind of rape, sexual assault. Okay, and if the partner is not around, if she has some social issues and so on, we have to dig during a pregnancy antenatal care. Okay, so that a company has to be there always. The family has to be properly told about the possible serious danger sign about depression, anxiety. Okay, and even after delivery, the complications of postpartum blues, depression, and psychosis also has to be addressed proper to the family. So usually it is supportive care in the initial setup, but if it is severe, we have to link her to the psychiatrist. So the other is what we going to do if she on anticoagulation for DVT treatment, medication, and she faced vaginal bleeding. Okay, so basically this is a complex situation that we are going to face in day-to-day of our hospital life. Basically giving anticoagulation, okay, and the patient presented with vaginal bleeding. Okay, it's it is a very difficult complex cases. Usually it needs individualization patient's condition. Okay, so the thing we have to weigh the risk and the benefits of giving these anticoagulants for DVT as well as treating for vaginal bleeding. But always we need to know the cause of vaginal bleeding initially, because if the vaginal bleeding is secondary to this anticoagulant effect, or is it secondary to the differential diagnoses that we talked previously, like APH and so on, has to be properly known because it is related to that one. But still, always whenever we try to terminate a pregnancy, we have to stop the anticoagulant a little bit, at least 24 hours prior to the termination process. How do you treat those with leech infestation? Usually we have to remove the leech. That's all. Okay, because it is the leech that's causing the bleeding, basically. So speculum has to be usually the leech is going to appear on the vagina or the cervix. Okay, so what we should do is we have to remove the leech. That's a major cause for the bleeding. What is the current recommendation regarding seat baths for episiotomy? Usually, previously, the recommendation was just a little bit of hot water, uh, at least 3 times per day, okay, for 50 minutes. But currently, the recommendation is not hot water. Rather, it's cold seat bath is a preferred condition currently. So the reason is cold condition like ice pack. They cause vasoconstriction of the vessels at the perineal area. Okay, so that the bleeding will be decreased. Also, the pain also will decrease. Okay, so the recommendation is at least to have this sit bath 3 times per day for 15 minutes, at least for 3 to 4 days. Some of the pregnant women might have morning nausea and vomiting up until delivery. These are rare cases, and usually 5% of pregnancies could be complicated by nausea and vomiting up until delivery. But always, after 4 months or after 16 weeks, if a patient suddenly presented with nausea and vomiting, we should be able to rule out other causes for nausea and vomiting. Okay, like pyelonephritis, cystitis, other causes of infection that could possibly cause the nausea and vomiting has to be ruled out, like gastroenteritis and so on things. Okay, it is uncommon to have nausea and vomiting in a severe form after the second trimester and third trimester. Um, I think the last question, how to treat pregnant women with stroke and DVT in primary health care. We're not going to treat in the primary health care center. These two entities are major conditions that cause life-threatening condition for the patient. One thing is we need to know the type of stroke, whether it is ischemic or hemorrhagic stroke, okay? And that also will define our management options. So I think this needs a major discussion on that. I think thank you very much.
All right. Thank you very much, Dr. Dawit. It has been a very interesting and clear presentation. Thank you very much for taking the time to present on today's session. And we
Very
hope
much.
we'll have future sessions with you with other topics as well. We would
Anytime.
also love to thank Ankara Technologies and NAT Project for sponsoring today's Blue Health virtual seminar. Thank you very much, Dr. Dawit. If you have anything that you want to add at the end of the session, please do so.
Well, my message is danger sign of pregnancy is a major point that should be discussed with a pregnant woman during her antenatal care. So all of us has to be able to understand at least the major danger signs, and we have to be thorough enough to tell them properly in a proper manner. Thank you all for your participation.